Hey everyone, this is Dr. Medicine Alex, and in today's video we'll be discussing about Incontinentia pigmenti. It is also known as Bloch-Sulzberger syndrome, and it is an X-linked dominant disorder that is commonly seen in females. Because this mutation is lethal in males, they have only one X chromosome, and the female is to male ratio is 20:1. So it is a multisystemic ectodermal dysplastic disorder with skin lesions that follow lines of Blaschko. This should not be confused with hypomenesis of Ito, where as well we see lesions along the lines of Blaschko, but there we see them as hypopigmented macules and patches in the form of whorls and streaks, and it is also an autosomal dominant disorder in contrary to Incontinentia pigmenti. So coming to pathogenesis, there is going to be mutation in the IKBKG gene, which codes for nemoprotein. So this nemoprotein is required for protection against TNF alpha induced apoptosis. So in case of this mutation, there is going to be defective regulation of cell division as well as a pro-apoptotic stage. Now coming to clinical features. So there is going to be cutaneous manifestations as well as extracutaneous manifestations. So these cutaneous lesions, they occur in 4 stages. It is important to note that these stages, the sequence of these stages is very irregular and their duration is variable, and there may be overlapping between the stages. So stage 1, it is also called as the inflammatory or the vesicular stage, where we see linear erythematous or vesicular lesions along the lines of Blaschko, and they present within the first few weeks to months of life. We can also see vesiculobullous lesions on the limbs, scalp and trunk, and they resolve within days to weeks, but they can recur during any febrile illness. Coming to stage 2, we see verrucous lesions. So in the form of verrucous linear plaques, they predominantly present on extremities and they disappear later in infancy. In stage 3, we see hyperpigmented lesions. So streaks and swirls of reticulate grayish brown hyperpigmentation is seen. They have scalloped edges, and they are seen on the trunk and intertriginous sides, and they fade with adolescence. Few areas of grayish brown pigmentation may persist even after adolescence. Then coming to stage 4, we see hypopigmented or atrophic lesions. So there is going to be linear hypopigmented bands that lack hair and sweat glands, and they are seen on the posterior aspect of limbs, and they can present anywhere from puberty to adulthood. Coming to extracutaneous manifestations, so there is going to be surface ectodermal defects. So there can be missing teeth or conical teeth, dystrophic nails, linear absence of hair and sweat glands, and asymmetric breast development or supernumerary nipples. Coming to eye manifestations, there can be retinal vessel abnormalities, there can be strabismus, cataract, microphthalmia, and optic atrophy. CNS anomalies in the form of seizures, motor and intellectual delay, microcephaly, and hemorrhagic stroke can occur. Skeletal manifestations, they are pretty rare. It can be seen in the form of skull anomalies or scoliosis, and other organal involvement in the form of pulmonary hypertension can be seen rarely. Coming to investigations, so histopathological examination of the various cutaneous lesions can be done. So in stage 1, since it is an inflammatory or vesicular stage, we can see eosinophilic spongiosis with some dyskeratotic keratinocytes. In stage 2, since it is a verrucous stage, we can see acanthosis, hyperkeratosis, as well as certain foci of dyskeratosis. In stage 3, since we see hyperpigmented lesions, they can be pigmentary incontinence, and in stage 4, since we see hypopigmented or atrophic lesions, they can be thinned epidermis and dermis, and which are devoid of adnexa. And MRI, brain MRI is necessary for assessing any neurological abnormalities, or if there are any functional neurological abnormalities, then MRI is mandatory. Then for ophthalmological abnormalities, it is necessary that we do ocular examination. Then coming to treatment, there is no specific management. All we can do is symptomatic treatment of the cutaneous lesions, and we have to keep monitoring for any retinal neovascularization, and if it is there, we have to treat it. And there is also necessary for to treat dental anomalies, a pediatric orthodontist referral is necessary, and also for CNS anomalies, a referral for neurologist is necessary. Genetic counseling should be done in order to tell the parents of the chances of recurrence of Incontinentia pigmenti. Thank you. Subscribe for more.